On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Chaos to Calm: Behavioral Management Strategies. My name is Megan Shetterly, and I will be your moderator for this program. Now I'd like to introduce our speakers for the webinar. Shawna Gigliotti is the Director of Training and Development at Belmont Behavioral Health Hospital. She earned her doctorate in occupational therapy from the University of Sciences in Philadelphia. Bausman has been in the mental health sector for over 13 years and is now the Chief Nursing Officer at Belmont Behavioral Health Hospital. Dawn received her Master of Science in Nursing from the University of Alabama with an emphasis in administration. She helps to build programs, processes, and protocols that support Belmont's growing mental health care culture. None of the planners for this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. So Shawna and Dawn, I will now turn the program over to you.
Thank you, Megan. Hello, everyone. We are happy to be here. Just for context, our behavioral health hospital is in the city of Philadelphia. We are a 252-bed facility, and we treat children from ages 5 and up all the way through adulthood. Today, our goal is to share the steps that we took to eliminate mechanical restraints. First, Dawn will go through and define what a restraint is to ensure we all have the same understanding. Then we'll engage you in a brief poll to hear your thoughts. As we move through the presentation, we hope you'll start reflecting on what it might take for your organization to make these changes. Next, we'll explore the profound impact restraints have on the people we serve. We'll walk you through the strategies and the tools that helped us eliminate the mechanical restraints. These objectives will be our roadmap for transforming the care. So let's dive in.
Hi, everyone. My name is Dawn Bausman. Thank you for the introduction. So this picture says it all for me, and I'm sure many of you have joined us today. What is the definition of a restraint? A restraint is defined as the use of any physical or mechanical device, material, or equipment that immobilizes, and I like to emphasize that, immobilizes or reduces the ability of a patient to move their arms, legs, or body freely. So we want to take a minute, and we'd ask that maybe you engage, if you can, utilizing the chat, and ask a few questions to get us started and kicked off here. I'm going to start with the first question. How many of you still employ mechanical restraints in your facility? I see we're starting to get some answers and appreciate it, and they're all yes, so I'm glad you're all here today.
It is eye-opening when you see.
So majority is yes so far, and that's what we have seen in other venues where we have shared how we were able to remove mechanical restraints from our facility. I'm going to move on to the next question. So I appreciate again your feedback. Have you or your patients ever sustained physical harm due to mechanical restraints?
Yes.
I like the nose here, and it really will show later as we move forward what we saw on this project. And for the final question, do you think restrained patients are more prone to re-experiencing trauma? Pretty sure I'm going to see all yeses.
Yes, the overwhelming yeses.
Absolutely.
Yes, I would also argue as healthcare providers who are applying these, we also experience trauma in the process. Thank you so much for your feedback.
Again, I'm really glad that everybody took their time out of their day to hear and listen to how this is possible for everybody. So the likelihood of injury typically increases due to high intensity nature of mechanically restraining individuals. Although many of you said that you haven't had injuries, I know a few of you have, and as have we when we did use mechanical restraints. But our data indicates that the implementation of Operation Last Resort at Belmont did not lead to an increase of employee injuries with the elimination of mechanical restraints.
Our other large push is trauma-informed care that led this initiative. The experience of trauma after being restrained, especially mechanical restraints, has been well documented, particularly in behavioral health settings. Research indicates that individuals with prior traumatic experiences, particularly those with a history of abuse, are more prone to re-experiencing trauma after being restrained, which, as we know, can impact our ability to create a healing environment as well as break down some therapeutic rapport. Some studies estimate that a large percentage, ranging from 25 to 50% of patients, may experience re-traumatization and psychological harm, depending on their previous trauma exposure. I've also had some anecdotal experience where people who have never been restrained before, it was traumatic either way.
Okay, so I just wanted to talk about that we did what really started this process of, along with a few other things, we did see increased regulatory pressure to reduce and eliminate mechanical restraints. The Joint Commission, the Office of Mental Health and Substance Abuse Services, Department of Human Services, federal, state, and local emphasis on elimination. So being in such a large facility and the population we treat, that would quite frequently be the main focus in a lot of our surveys would be, the use of mechanical restraints, the documentation around it, and how could we move forward in eliminating restraints.
One evidence-based approach that we utilized during this was the 6 core strategies to reducing seclusions and restraints. So now that we've walked you through and we've set you the stage for why change is so critical, we're going to walk through our journey, and this is part of it. We definitely use this as an outline to apply a strategic plan. The strategies are designed to create a safe, trauma-informed environment that minimizes the use of these interventions. We'll review how we used each of these steps throughout the way. The first step being leadership towards that organizational change, the use of data to inform practices, workforce development, use of seclusion and restraint prevention tools, incorporating peer support services, and debriefing techniques. In addition to the support of this work, we use 2 performance measurement tools. The Plan, Do, Act study cycle was instrumental in guiding our continuous improvement. We could plan our interventions, implement them, study the results, and adjust accordingly, ensuring that every step we took was backed by data and reflection.
We also use the WINS change model, which influences the culture shift within the nursing department by focusing on unfreezing current practices, so utilizing mechanical restraints, moving toward new methods, and reinforcing these changes. This mindset was embraced and transformational during the journey. And I do see in the chat, and I think we should answer this question now. When we say restraint free, does that mean, this is from Elizabeth, no devices, assuming folks still use manual holds? And yes, you are correct. We still do utilize manual holds, but we do not use mechanical restraints.
We realized that implementing this, we heard a lot about some barriers. And the biggest barrier, I believe, we heard in the resistance was fear. People were afraid of getting hurt. They kind of thought it meant that we were going to let people do whatever they wanted. And they feared really losing control, particularly around milieu management. And the uncertainty really lingered. We also realized that our training practices had to change. Employees really lacked the understanding of why we had to do this. They lacked trauma-informed training and de-escalation techniques. And people lack the confidence in utilization of manual holds as well as other forms of de-escalation.
I'd like to say during this time as well that that was probably one of the biggest barriers we have, you know, the fear of change, and giving our staff the tools to overcome those fears was instrumental in this project. So, what are Belmont's philosophy on restrictive interventions? So, regular restraint use is not standard of care. And I emphasize it is not standard of care and should be considered a strategy that requires careful consideration and consent in the same fashion as other medical interventions. Another one of our philosophy, use of restraints is still the last resort and show evidence of exhaustion of all other methods of de-escalation on the part of the patient's treatment team. And we'll get into what those interventions look like. For a traumatized population, the risks of restrictive interventions will often outweigh the benefits and may escalate a situation or rupture a relationship with the treating team. And then finally, reducing restraint usage is a responsibility of every direct care clinical team member and leader. And you'll see as we move forward how we couldn't have done this if we didn't do it collaboratively with all disciplines and what it took to get there.
We'll dive into now how we implemented every core strategy into our strategic plan.
Okay, so our goals towards organizational change. I sometimes really go a little off in this area, so bear with me because I get a lot of excitement sharing this. And I think this is, you know, the part of this presentation, which hopefully will get you excited as well. So what was our commitment to our employees? The commitment to our employees, we offered additional training and education. The executive team, the nursing leadership team were committed and the same de-escalation training as all direct care staff. So all the training that direct care staff was also given to all of leadership. A representative from leadership responded to every aggression behavioral code. So in our facility would be called a psychiatric code, would be called a code 22. And I frequently talk about this part here and what that looked like. So I'm just going to give you a little bit of what that may look like. So if a code is called in a psychiatric emergency, meaning that the patient is in imminent danger to self or others, we call a code and ask for support. And at this part of the project and how we utilized this was that we had every member of the interdisciplinary team show up at the codes, offer support, provide de-escalation, utilize the training that we have implemented to show staff, the frontline staff, that we didn't have to resort to using mechanical restraints. We did that by showing increased de-escalation, how to manually, well, the training included manual holds, but that it was okay to manually hold a patient in the space that they were, that we didn't have to restrain them, to remove them to a quiet room or a bed that had straps on it, and showing staff that we could do this by being there and, you know, in numbers. This is really what started the push in the right direction. We also offered code debriefing sessions immediately following every code. So talking about what went right, what went wrong, what brought the patient to this point that they were so, you know, upset and agitated or, you know, wanting to self-injure. What could we have done differently? Were you comfortable? Did anybody get injured? And again, this was another key piece in us moving towards removing mechanical restraints. And then all episodes of utilization of mechanical restraints required notification to a member of senior leadership. So this part of the products, we slowly implemented different interventions to reduce the mechanical restraints. So I'm going to just give you an example of in a hospital of 252 and 11 units, we would have restraints everywhere, right? You'd have restraint bags all over the floors, in the medication rooms. The first step was to remove the restraints from the units and put them only on one unit per floor, so that everybody had to do the best they could, utilizing their de-escalation skills, maybe some medication management in order to de-escalate the patient and not put them in mechanical restraints. The next step was removed all the mechanical restraints off of the floors and down into the nursing supervisor's office. So this is even, they had to take a greater step and utilize more of those skills and tools to prevent the utilization of mechanical restraints. Lastly, we implemented that if a patient required mechanical restraints, the approval must have come from the chief nursing officer or the chief medical officer to be able to use those mechanical restraints. And if you can imagine, by that point, everybody has tried everything they can to make this patient safe without further traumatizing them by putting them in mechanical restraints.
I see the question about training materials. We'll get into training in depth in a few slides, actually. We using data to inform practice, regular collection, analysis, and sharing data related to seclusion and restraint use help to inform decision-making. This includes monitoring patterns, identifying trends, and using data to drive improvements and track progress. So we used and looked through this data in a committee called our Restraint Reduction Committee and Trauma Informed Care Committee. And the way we displayed data kind of changed over time. I have a couple years reflection here. We wanted to make it accessible to everyone. We didn't just want the committees or the leaders looking at data. We had to post the data. And we wanted to make it accessible for people that might not always be looking at charts and data to understand them. So we started in this. We tracked data hour by hour as well as by unit. This hour by hour data really evolved into how this is represented. We used, when we used mechanical restraints, the orange would be mechanical. And then we would go into unit by unit. So every unit had a breakdown of the pie, and they would see what their unit's monthly data reflected, and it kind of added to a little competition of who could be the lowest as people were walking through the employee entrance, seeing this data represented and seeing where we were each month. Workforce development, this was a huge piece. Communication and philosophy, like Dawn went over, but when we focused on the workforce development and the 6 core strategies, we had to launch a full campaign. We realized that we needed to get people excited for it. We called it Operation Last Resort, and it reflected our commitment to using restraints only as a last resort after all interventions had been applied. We created a logo and incorporated it into all our communications across the hospital. We gave away little badge buddies with the logo on it. It was a visual reminder that helped reinforce the expectations. Training and development was a huge portion here. Training is when I first started really, well, de-escalation really lied in the hands of all nursing employees. I'm an occupational therapist by training. It was a part of our clinical services department, and it never really understood why we weren't multifaceted in this approach. We have skilled therapists on site, leaders, people with a lot of education. Why are we just relying heavily on our behavioral health associates to always do this? I realized that we had to get other disciplines involved, including leadership. We had trainers for our behavioral management model, which is therapeutic options. You might be familiar with Handle with Care, CPI. Normally, again, it was all our behavioral health techs that were trained as trainers. We got leadership, we got case managers, we got clinical service members, therapists, all different roles trained, and we strategically paired a therapist or a clinical leader with a BHA or a floor staff member from nursing to be able to reach all of our employees and see different perspectives and collaboration. We also had a transition of leadership of our restraint reduction committee to myself, who, like I said, was as an occupational therapist, Dawn, who is a nurse and was the DON at the time, and a floor staff member, one of our clinical BHAs, all as a co-chair of this committee. We all had a shared responsibility and a buy-in here, which we really saw results in. We also saw all levels of leadership or disciplines represented on a committee for the first time, which again empowered people, brought voice and choice to things. Part of our, the occupational therapy team developed sensory rooms and sensory awareness programming hospital-wide, which became a key role in some of our de-escalation. It was another tool in the toolkit for people to utilize. We then also implemented skills clinics as a part of our training, where we would take one theme, right? So we take a theme that we were really struggling on, or a specific hold or de-escalation technique, or just one theme that we realized we were struggling with as a whole. And we did strategic implementation of education around that. We had monthly skills clinic themes. We then decided to, again, our hospital functions really nicely in competition. So we started acknowledging people as restraint reduction champions. We saw the decrease over time. We had to reinforce positive work, and we made it our point to celebrate all of our wins and get really excited. This also included an end goal that the organization agreed to. If we went 100 days mechanical restraint free, everybody in all disciplines got $100. So that really fueled the fire. We celebrated our 30 days, our 60 days, our 90 days, our 100 days, our year, and we continue to kind of roll this initiative through. I mentioned a little bit about our restraint reduction tools. A lot of those were de-escalation. We did verbal de-escalation. We added another behavioral management system to our toolkit. It's called Ukeru. We opened a STAR unit, which is for the neurodivergent population, and realized that when we went into restraints at the time, or we even would do a manual hold, we realized that we became the new stimulus to people, or we became the tool for de-escalation. Adding that system, which was trauma informed, helped us give everyone a framework of de-escalation, as well as provided an additional tool before we had to implement any hands-on approaches. The sensory rooms were key to this as well. Spaces for de-escalation, tools, items. Everyone has access to them. Everybody is educated on how to use those. We use consumer roles in inpatient settings. So after any mechanical restraint episode, we would interview both the staff involved as well as the patient involved, and got qualitative themes that we could then use to inform future trainings or address issues or breakdowns that we saw. And Dawn had talked a lot about debriefing, but debriefing was key. We really had to make it a safe place to not blame and shame, but to support and move through. People really started to appreciate that space to, check in. Is everyone okay? Are we doing all right? What could we have done better? It improved our teamwork. Being such a large facility of having 700, 800 plus employees, it's really difficult. That's the biggest feedback I think we received, to grow and develop teams over time and increase teamwork and communication amongst such a vast employee population. And debriefings really served as a safe place for all of that. And I see a question. Are patients able to be in the sensory rooms without staff, or is staff required to be present in the room?
Good question.
That is a great question. So our sensory rooms are leveled in a green, yellow, red level of supervision. They can't, green items are allowed to be used outside the space. That's low risk items such as like a stress ball or noise canceling headphones. And then our yellow and our red items require a line of sight into the sensory room, or if you're using a red item, the staff must be present in the room and are required to handle the materials. That could be things like anything with a cord, such as a light projector or an essential oil diffuser. A yellow item could be something like a therapy ball. If somebody is kind of bouncing on a therapy ball, there's risk of, someone falling over or injury. We want to make sure that we're using all tools safely. We've vetted all that through our risk department and worked very closely with all teams to ensure that everyone is on board. Everyone receives that education as soon as they become an employee. And finally, we studied our intervention. And this is what we did. And we found out that it was a really difficult process that involved a lot of what do I want to say? Modification over time. It wasn't a perfect process, but the main thing really kept us going is that we all had the same vision as a team. We had a very strategic timeline. So this timeline was, again, like I said, it didn't happen overnight. In 2020, this is the initiation of Operation Last Resort. It's when a strategic plan was in place for Belmont and the 6 core strategies were utilized to implement this plan. November of 2020, we talked about adding an interdisciplinary at various skill levels to our de-escalation behavioral management tech system, therapeutic options. So we paired those people together strategically, like I reflected on before. We realized that we needed to incorporate more frontline staff into our committee, which helped us to bring in and change leadership of our restraint reduction committee, which I said was myself, Dawn, and one of our clinical BHAs. And it redefined how we looked at this. We also added more frontline staff into our committee for their feedback and required physicians be there as well. So every level of care was represented. In the middle of this, the funnest thing we did was move from a one hospital to a big hospital we built directly behind it, which was a huge change in environment. We went from 180 beds to 252 beds at this time, and we moved all of those patients into our new building. And we knew with the change of environment was going to add some change of some more fear and change in process. So the committee took that very seriously, and we did environment of care scans for safety issues such as code response times, routes. The building went from 2-3 floors to 6 now currently, and how we responded to that and how long it would take us to respond. The committee worked closely with the hospital command center team to find alternative solutions.
Just want to add real quick, Shawna's doing an excellent job here explaining this timeline. But with that transition, we recognized that we had already started this project. And when we got into the new hospital had restraint beds in them, and not restraint beds that we were used to using in the old hospital. So I don't know if anybody's familiar with the old school wooden restraint beds. And then we went into the new hospital and we had the hard rubber with the metal pieces restraint beds. So that took on a whole nother project in itself. We literally had the plant operations remove all the restraint beds because we had come so far by this point, and go into the old hospital, take those beds out and put them into the new hospital, as well as Shawna and her team offered additional trainings if at that time, when we still were using as a last resort restraints, how to utilize those beds with mechanical restraints.
Yeah, so we moved and we realized with the new environment that we had an increase of acuity along with an increase of mechanical restraints upon our move. We had gotten 30 days, 60 days at a time. We would go backwards to 0 days. People were a little frustrated, but also like, okay, we got to do better. But the new hospital threw a wrench in that for us. We knew we had to move quickly and identify themes and kind of fix them. So we did video reviews, mock codes, code cards, more effective and targeted de-escalation interventions, more staff debriefings, code response improvement initiatives, and we did skills clinic conducted by the therapeutic options instructors to address the themes and trends of acuity that were preventing de-escalation. We attacked them kind of head on as a group, and we realized that teamwork made the dream work. We realized that staff comfortability started to increase with de-escalation. They knew we were there. We backed them. We were on the floors with them, and the data really started to reflect it. So in January of 2022, we had our first month that led to our elimination, I will say. We've gotten here before, but 0 mechanical restraints. We celebrated our 30 days in January of 2022. In February, we celebrated 60 days. And finally, in March of 2022, we achieved 100 days, $100. We were no longer using mechanical restraints. Dawn and I ran out of that building with all these restraints and threw them in the dumpster.
That's great.
We were very excited. We planned a 1-year celebration, and we explored, again, implementing the trainings like Ukaru into our tools. We are rolling out UGRU throughout the entire hospital still to make sure that we are continuing to be trauma informed. And on December 22nd, on December 4th of 2022, our organization celebrated the 1 year as a collective, and it was an amazing turnout. People were so excited and very happy we continued the day count, and we had a big celebration with everyone and everyone's hard work. So throughout 2023, we obviously Dawn and I threw out all the mechanicals. They were no longer a part of it. We changed new hire orientation to not only have therapeutic options, but UGRU training as well. And we incorporated Path to Purpose, which is a corporate initiative from our corporate company, Acadia, which added more trauma-informed, experiential, patient-simulated experiences into our new hire orientation for every new employee. And we rolled out our Operation Last Resort plan into our crisis center as well. Today, we've transitioned our restraint reduction committee to our Zero Harm Committee, which supports our Peace Initiative, which is a new initiative, which is to reduce peer-to-peer assaults. We have a high level of violence with our population, and we continue to meet monthly, review data, fill education gaps through training and education. I'm always wondering, what can we learn? What more can we do? And we learned that as a team, we could really achieve great things if we all come together and on the same page.
I also like to bring up too, I think, whether you work with the mental health population or you're in a med surg facility or, a nursing home, I think, some of the tools we have here and some of the information you'll find that in all of these settings, you could reach this goal too of not utilizing mechanical restraints. And I see a question, particularly in dementia population. We do not have patients with dementia, maybe early onset or some, the level isn't too high when it comes to that population for us. But I do believe utilizing some of these strategies and tools that it's possible for everybody and all facilities to utilize this. What are some of the ethical considerations?
When we launched Operation Last Resort, our first priority was to ensure safety for both of our staff and our patients. We knew from the beginning that an increase of injuries would be an unacceptable outcome, and we were committed to preventing that at all costs. To mitigate any risks, we approached this journey slowly and methodically. Every step we took was measured, and we relied heavily on the data to inform our decisions. Throughout the process, we reviewed both qualitative and quantitative data daily to ensure our interventions were not only effective but safe. What we found was a shift in our practice that resulted in zero increase of injuries. The data reinforced our belief, and that slow incremental progress, combined with active leadership commitment from the top down, was key to our success.
Okay, so I see a couple more questions popping up here. And did we see an increase in chemical restraints with the elimination of mechanical restraints? No.
We maybe have 1 a year, 2 a year, max.
Yes. Along with mechanical restraints, the use of chemical restraints is something that regulatory bodies, love to look at as well. So we have also managed to decrease any type of chemical restraint along with the mechanical restraints in our facility. And I also wanted to just add here that our facility is, if you're not familiar, we are in the city, our population, we have very high acuity. Shawna mentioned earlier that we do have a crisis center. So we have a children and adolescents crisis center that the children and adolescents can go to in crisis and basically, then come to our hospital for the next level of care. So as you can imagine, the acuity that comes with that population is quite high. And then I always like to bring up something that one of the staff have said to me after we reached all these milestones and goals in removing mechanical restraints. They're like, One particular behavioral health associate said to me one day, and she said, Dawn, she said, um, we have the same patients, but we're not using mechanical restraints. And I said, you're absolutely right. Why do you think that is? Because, like many facilities, we have, repeat patients and the same patients coming back and forth when they need our care. And she said, because you know what? We know now that we don't have that as an option, and we meet the patient at the door where they are instead of knowing that we have that option of using mechanical restraints. With that means that that level of care just became much greater, more therapeutic, less trauma. So that gives me the chills now every time I talk about that we are still treating the same population, the same acuity without the utilization of mechanical restraints. And I also want to add, when I first started at Belmont years ago, I've been there almost 10 years, that was the only option. And I say this because that was the mindset, and I believe the stigma that came with this population. The mindset was that the only tool that we could use to de-escalate this patient was to put them in mechanical restraints. So restraints may have been on the beds when you got there. People didn't de-escalate. There was no talking. There was no intervention. It was that's the only option we had, was to put those patients in mechanical restraints. And to see this transition and watch it and how far we have come. Not only Belmont, I know a lot of facilities are transitioning to mechanical restraint free. It gives me chills, and I'm just so happy that we're able to share this and our project with many people, and we have really taken this on the road. So lastly, I just want to say that with leadership commitment, it helped build the culture where the use of mechanical restraints was seen as a failure, right? But not just for the patient, but for us as caregivers. We believed in our plan, and because of that belief, we achieved an incredible milestone. And it's with great pleasure today to say that we have been mechanical restraint free for 1,153 days and counting. We started our journey, as Shawna said, on December 5th, 2021, and we are proud to stand here today and speak with you with this achievement. And the best part of this accomplishment is to know anything is possible when you have a clear plan, commitment to see it through. This journey has shown us that in the right support, we can truly transform the way we care for our patients.
So at this time, we're going to open it up to questions. I see we've dropped a lot in the chat, and I am going to go through and start answering them. So we answered. There was one question I saw about sensory rooms and basic items. A basic sensory room list. It is best, and actually it should be, overseen by an occupational therapist, if I'm being honest, to implement it. It doesn't have to, everyone can use it, but it's best when it's informed and created by one. And there are definitely lists of items ranging from, I could share some resources, but ranging from stress balls, yoga mats, light projectors, different types of textures, all of those things. We could, I could share a list with you guys soon. We talked about the dementia population. Did you see chemical? Okay. So we have, as we decrease our manual holds, we don't do any seclusion, but our manual holds did increase, obviously with no other option. They increased from, I would say we've struggled with our increased acuity and our manual holds over time. And but the duration is definitely less in our holds. And like I said, we don't do seclusion. We average probably, I'm going to be honest, 2024 has been a high acuity year, and we haven't seen a large increase in our manual holds, which has just kind of informed us to go back to basics and kind of start implementing some of the things from this project, actually, which we're doing now. I see a question, did this put a heavy strain on the security department? The security department does not respond to behavioral codes in our hospital. They're led by clinical staff, and under like the nurse's license. Our security team is trained in our de-escalation the therapeutic options that I was referencing, our behavioral management system. However, they are not our first line to ever go hands-on. It's only because they're in admissions and they're patient-facing at times and they're receiving patients. It's for kind of their own protection. However, they're not engaged with us.
When you do physical hold, what typically time frame for the length of that hold? So for us, we've kept the holds under 30 minutes. Along with state regulations, we've never put any patients, any age, in a hold past 30 minutes. Right now, our average time, although like Shawna said, we have seen an increase in manual holds, ebbing and flowing throughout the years. But typically now our manual holds are less than 5 minutes. Can you discuss your staff debriefing process? So yeah, absolutely. For us, when the staff members respond to the code, we do everything possible during the code to de-escalate. If the patient had to go in a manual hold, we would put the patient in a manual hold. But then we would identify a leader or a team leader, and we'd ask anybody that participated or was part of the code or the staff that may have been there, working that floor. We'd step in an area where it was away from earshot of patients, and then we would just ask questions, like I said earlier. What do you think went right? What went wrong? What did you see leading up to this code? Was there anything we could have done to stop the patient from getting, that upset that we could have stopped prior to the code? And a lot of times now, what we see is all of those efforts are made prior to even calling the code. So staff on the floor are utilizing that training. They're utilizing the debriefing. I'm sorry, not the debriefing, the de-escalation, offering the sensory rooms. And then when they reach a point where the patient still, is upset or agitated, imminent danger of self-harm to self or others, the code is called. So then we just, is everybody feeling safe? Is there anything you can identify that maybe there was a wrong technique used in regards to therapeutic options? So basically that's what we utilize, and we took that back to our committee.
And we collect all of these staff debriefings, they're documented. And from that informed our themes to either discuss in the committee, decide on interventions, and like Dawn was referencing, if there's a particular hold that people are doing incorrectly, informed targeted trainings. It could be a one-to-one training, could be a large group training for those things. What type of de-escalation training do we use? We use therapeutic options, which is a company, it's like similar to like a CPI or handle with care. We also use, it's called Ukaru. It is a system that's heavily trauma informed. It breaks down how trauma impacts the brain, what our job is as providers, it encompasses. I really love the fact that it encompassed how it was one of the first trainings that I've seen that didn't ask you to separate your humanism from your professional self. I think when I was in OT school, it was like, when you get to the door, you're the job. And that's not easy to take off your humanity or your person, but instead it tells you to embrace, reflect, and be aware of it, and add tools in your own toolkit to manage it and work it as a team successfully. We also did sensory trainings. We did verbal de-escalated trainings. We did simulated role plays along with those. Thank you for the congratulations.
Yeah, thank you very much.
Let's see, with the staffing ratios.
Staffing ratios. I knew that question would be asked. A lot of times it is when we're presenting. So for us, I'll just give you an example of what it looks like. And, every facility is a little bit different based on acuity. Our hospital is set up where we have 28 bed units, male and female, and we would have 2 nurses and 5 behavioral health associates. But if there's high acuity and we need to staff additional staff, or if this patient's on a 1-to-1, we take into a lot of things into consideration when staffing our floors. I hope that answered your question.
Restraint free for 1,000+ days. Did employee injuries increase, decrease, remain the same during this time frame? There were no increase, and I would say they remained relatively the same.
Yeah.
With all the training, that was a major importance and emphasis for us. We wanted to make sure people felt safe and had tools in their toolkits.
This is one of the things I really was proud of our team in this transition when it came to, as you know, putting somebody in mechanical restraints, you strap them in the bed, and then you can kind of walk away with one person monitoring that patient. When you're in a manual hold, it looks a little bit differently, right? You need a set amount of staff to be able to safely restrain a patient, to keep them safe. But again, during this process, we really saw staff join together, support one another, be there, offer, who needs a tap out, people step up in the leader role, how we were going to, place a patient in a hold, when we were going to release the patient from the hold. You would think that you would see an increase in injury, but we did not at all. If anything, we saw more support to one another during these crises.
I don't see any more questions in the chat. I hope we answered them the best we could and didn't miss anybody. We'll give you another minute or two if anybody has anything else.
Hey, Shawna and Dawn, it's Megan. I had some questions as well.
Sure.
Just and thinking about what you were saying about, obviously addressing when something or someone is escalating. But and I think you talked about this, but kind of going like upstream, I guess I want to say, to, when that patient's admitted, assessing them, doing the care planning process. I'm sure it's all starting way back then. And I just wondered, like, is that the case? How did you incorporate that into this whole process as well? Am I kind of correct in making that assumption?
I'm sorry. Could you repeat the first part of that question?
Yeah, so like the patient themselves, like before they get into a space where they're really escalating, I'm
Yes.
sure that that patient, like before that even happens, there's some care planning, team planning processes that are going on to identify the potential for this and what their situation is so that there's kind of this care planning
Yes.
process. I've heard like some organizations say, like sometimes they'll identify there's a propensity for somebody to start kind of escalating a certain time of day. And so, and like maybe it's an adolescent. So they give them some
Yes.
opportunity to do some gym time. I don't even know if you have a gym, or
Yes.
Yes.
rearrange the dinner so that they can kind of work off some of that aggression.
Absolutely. So like Belmont Health System has a like continuum of care that's been really beneficial for communication handoff. So Dawn had mentioned before about our PCCRC, our crisis center. We often, when we get a lot of referrals from there, we get a full report on how that patient is doing, and we plan from the door. Or admissions, say we don't know, and this person comes via ambulance or whatever. Admissions on intake will give us a call and be like, and hey, this person seems kind of agitated, we could use some support. I've created some sensory items or even like activity-based items to keep in admissions, just to kind of provide some opportunities and options. We team around people as soon as they come in with that.
Yeah, as well as, treatment planning, assessments from the door, any referral information. What are some of the triggers
Mhm.
for this patient? What is their trauma? What is their precaution? So are they aggressive? Are they suicidal? All those things, like Shawna said, and you're asking was from the door, along with treatment planning every day with the interdisciplinary team, medication management. And yes, you're absolutely correct that we can identify. And I want to preface this by saying that with that 252 bed facility, half of them are children and adolescents. So anybody that works with children and adolescents know that the struggle there, right? And what regulations come along with that and the trauma that they're coming from. But yeah, so we're able to, work day in and day out, and that patient that may not do well going to sleep at night, right? Because they had trauma. And their way of expressing that is by becoming agitated or hitting their peers. So recognizing that, communicating it to the team members, BHAs through physicians, and then what intervention can we utilize for that particular patient during that time to decrease that level of agitation, fear, and trauma that's happening with that patient.
We also offer along with the treatment plan, we have a robust therapy team that has a lot of disciplines from occupational therapy, more traditional processing therapy, psychotherapy, art therapy, dance movement therapy. We offer behavioral BCBA. We offer, on top of obviously our main thing is groups, but we offer individualized treatment. We also offer one-on-one therapy sessions. We team around people. And if anybody else works with children and adolescents, as Dawn was saying, our length of stay for children and adolescents due to the lack of resources we've seen over time has greatly increased. And we see people cycle in and out of stability and maybe even learn new maladaptive coping skills. And we continue to meet as a large group team and add different interventions, different therapies, and different treatment interventions throughout their stay.
Great. Hey, you may have answered this already, but what was one of your hardest, like biggest challenges that you actually faced during the whole project? Was there one thing that really stood out?
Oh, there's a lot.
I would say initially
Resistance.
staff resistance or inability to wrap their heads around how are we going to do this. The abnormal became normal, and that's what I like to say. Their resistance, but fortunately for us, we quickly overcame that. And as Shawna mentioned in our timeline, it then became more about how can we keep this going in the right direction and that competitiveness and what unit went the longest days without the use of mechanical restraints. And that's where we kind of started to get a lot of buy-in and a lot of communication around this. But I would say staff fear was the biggest barrier for us initially.
I think so too. I will also say this is kind of, I feel like nobody talks about this. When you lead an initiative this large and you lead something that's a change in culture and you're the face of it and you become the problem. Like it's almost like you feel like you have to know all the answers to all the questions and every right possible thing to do. And that is a lot of pressure. And I would just realize that if you are starting to lead this and your organization is, it's not all on you as a leader of the initiative to have every answer. We're not going to have the answers. It's bringing the right people to the table and actively problem solving. But I would say initially too, it was like in these codes where we would normally go to mechanical restraints and having different options, people are all eyes are on you. And it's like, okay, well, what are we doing right? And I think that that's something that we don't talk about because the success has been there. But the reality is it is a lot of pressure. It's a lot of having to do self-reflection for yourself to make sure you're not carrying all the weight and also realizing that you're human and you have your own stuff to table as well. You're not going to be perfect in every de-escalation. Not every patient is going to respond to you in a way. So it's like sharing the power there, which is really, really strategic and was instrumental to, again, our success.
That's great. Hey, one other question. How did your physicians support this project? Just curious.
So yeah, initially we had to get all physicians, as we said earlier, trained in de-escalation interventions, which they, were sometimes hesitant or, couldn't find the time to get to these trainings. So the first thing was to get them trained in these tools for interventions, including therapeutic options, meeting separately with the medical team in this process. And there were times, and I'll be honest, that physicians may have said, well, we're going to use restraints. I'm going to order the restraints, and us having to make the decision. No, that's no longer an option, Dr. So-and-so. We're not going to use mechanical restraints. What else can we do? But slowly but surely we got the buy-in, and after the training, we saw more physicians at our codes participating in a manual hold, quicker to give the medication order if their, medication intervention was needed. And now it's just part of, it's just what we do. So their involvement and engagement has increased over times, and now it's just we all do it together.
Yeah. Great information. And it seemed everybody obviously was very interested. There was a lot of questions coming in through the chat, even when you were doing your slide presentation. I'm just looking to see if there's any more questions coming in, but I'm not seeing anything. Did you guys see anything that I missed?
I don't think so. I think we're all caught up.
Yeah. No, I think it's great information. And just another kind of tidbit. You both had written an article in the Patient Safety Authority's Patient Safety Journal. I think it was May of last year
Yes.
when you published that. So, you know, just another good piece of literature and resource for people, which I think you have in your resource list as well in your
Yes.
your presentation. So just encourage everybody to read that or reach out to you, obviously, if they have more questions, because there seemed to be a lot of interest in that today. So I think great webinar. So thank you for sharing. So
Thank you.
Thanks for having us.
and somebody says this was excellent. Thanks for sharing and kudos.
Thank you all.
Thank you.
You and this amazing work. Yeah.
And we love spreading the good work, and we are not gatekeepers of any of it. So please feel free to reach out to us. We love making this field more trauma informed and safer for everyone.
Yeah, awesome. Thank you. And I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and or the certificate of continuing education, please feel free to direct any of those inquiries to Shelley Meixel at shmixell@pa.gov. And this concludes our webinar for today. Thank you.